I'm going to go through some housekeeping slides about how to use GoToWebinar. And I'd just like to informally remind everyone that the peer calls are an opportunity for discussion, and that if you have a question during the course of the call, please feel free to use the methods I'm about to talk about to ask a question at any point, so that we can be as responsive and as informative as possible. On your screen, you should see the GoToWebinar control panel, which can be opened and closed using the orange arrow button as shown on the screen. If you'd like to view the presentation full screen, you can use the full screen button. For your audio options, we strongly recommend that you use the phone to call in. However, if you'd like to use your computer for the audio, you can do so simply selecting the audio choice that you'd like and following the instructions within the panel. For questions, you have two options. You can either select the chat box and expand it and type into it in your GoToWebinar control panel, or you can raise your hand using the raise hand button on the control panel, and I can unmute you so that you can ask your question directly. In order to keep the line clear and so that everyone can hear, participants are muted currently, but we can unmute you to ask a question. If you have difficulty hearing a speaker, please feel free to use the question or the chat box to let us know, and we'll be happy to try and adjust as best possible. As always, all of our webinars are recorded and will be posted on our website within 1 week of the call. With that, I'd like to hand the call over to my Executive Director, Robin Phillips, to introduce our speakers and get started. Robin?
Hi, thanks everybody for joining us today. Frank Thomas and I have worked together for a long time, and he's a real innovator and really a great transit manager out in the Eastern Oregon area. So he really works with a rural area. And he's sharing this study that's really exciting, and he took a lot of initiative to make this happen. And I think that that's what's really exciting about this, is that he didn't wait for something to happen to him. And with us is also Nick Ducote from Ducote Consulting, who answered the RFP for Frank and will give us a lot of information. And please ask questions about methodology and how this worked and how they're planning on using this. So with that, I'll give it to Frank, and he can talk about how this started.
Thank you. Good morning or afternoon, depending on which time zone you're in. I'd like to give you a brief history of how this project came about, because it'll help inform some of the metrics that Ducote Consulting will be talking about in a few minutes. The first thing I should probably tell you is that our program predates Federal Transit Administration's efforts by, well, at least a year. In fact, we started calling ourselves Rides to Wellness after hearing about the federal program, because we didn't accurately have a descriptive name for what we were doing, and it seemed to fit. So we're not one of the projects that's presently funded under FTA's grant. Well, funded yet. Our project actually started back in 2013 when our local hospital performed their very first community health needs assessment, which was mandated to all nonprofit hospitals under the Affordable Care Act. In their initial survey work, they didn't ask about mobility or healthcare access explicitly. However, their respondents kept leaving references to it in the open-ended questions that they asked and in comments that sometimes got scribbled in their margins. And to Grand Ronde Hospital's credit, they recognized that they were onto something right away. In Oregon, I'm in a really lucky position in that we have a really common sense approach to Medicaid. We have a model called coordinated care organizations, and these are regional networks of healthcare providers who have agreed to work together within their communities to serve people who receive coverage under Medicaid, or in the state of Oregon, that would be the Oregon Health Plan. They're focused on common sense, community-driven approaches to prevention activities and helping people manage chronic conditions. Their specific cost savings objectives, at least in my region, are, they include things like reducing use of the emergency room, preventing hospitalizations or rehospitalizations by effectively treating ambulatory care-sensitive conditions, and giving people the basic support they need to live healthy lives. There are 16 coordinated care organizations in Oregon, and I happily fell into the jurisdiction of one of the ones that's the most forward-thinking and melds the best with the personality and culture of our agency. So upon review of their community health needs assessments results, our hospital approached Eastern Oregon Coordinated Care Organization, who then invited us to apply for a community transformation grant to help address the identified need. We pitched a really aggressive upgrade to our existing systems, which was essentially based on our existing ADA paratransit system and, to a lesser extent, an expansion of our brokered Medicare or Medicaid work. The new capacity we created was intended to allow us access or ability to do same-day, door-to-door, demand-responsive access to anybody with a medical need, more or less anywhere in our county. The Coordinated Care Organization loved what we put together. In fact, they funded it for precisely 2/3 of what we asked for, and after that, the real work started. The first probably 12 weeks of the program, we were just busy retooling our shop and hiring and training staff, so there wasn't very much produced in the way of service. We found out right away that the very same healthcare providers who were really eager to see us address their perceived mobility need were not very enthusiastic about sharing data with us. For what became understandable HIPAA compliance reasons, we couldn't get much in the way of baseline information or feedback from the very people we were trying to serve. I mean, if they had told me, look, here's your top 15 users of emergency room services, go out, take care of them quickly, we could have moved the needle in dramatic ways for very little money, but obviously that wasn't an approach that was going to work. Fortunately, we had been using Adept by Stratagen as our trip reservation and accounting software for long enough that we had 2 full fiscal years of ride history to draw from. So when Stratagen did their initial install with us, one of the first things they handed us was a full data dictionary, and then they pointed us to Microsoft Report Builder. If we'd been with a software vendor that considers their product to be a black box and that only their developers can write queries against, we might have been in a bit of trouble. Our mobile data computers capture 169 data points every time we perform a pick or a drop. So we had a wealth of data to mine from for common characteristics of what same-day medical trips look like. After using a 2-year sample, what we found was that prior to the Rides to Wellness program, we were averaging about 20 same-day accommodations for medical access every month. And these add-ons really only happened when the planets aligned. So, for example, an ADA paratransit rider cancels an appointment on an afternoon, and that creates space for somebody who just happens to call the very same day and happens to have an appointment need that falls into that service window. Of course, the problem with that is that all of the accommodations are long shots, and as a result, almost without exception, the trips that were provided on that basis came in our most populous community where fixed routes and ADA paratransit are available 6 days a week. If you lived outside the ADA area of service, there simply wasn't a solution for you. In fact, one of our primary challenges when we launched this project was retraining staff and passengers alike. I mean, after a decade of restricting door-to-door access to people who were prevented from using a fixed route due to a disability, even then, you had to schedule a day in advance. Our new model was a little bit confusing. It didn't take long, though. Within 6 months, the genie had completely come out of the bottle. By December 2014, we were serving 120 same-day medical trips a month. And about the same time, something that we didn't really expect started to crop up, a couple of somethings actually. First, passengers with chronic conditions such as dialysis or oncology, they started scheduling their trips way in advance, sometimes up to 2 weeks in advance, the maximum our system would hold. We also started fielding requests for out-of-market travel because as a fairly small hospital, there are certain specialties and services that just aren't provided in our area. And some people may need to travel, 175 miles to Boise or a couple of hundred miles to Portland to get that life-saving service. Since there wasn't anything explicitly in our grant that prohibited us from providing either type of trip, we decided to take them on. So the basis for what became an eligible trip got boiled down to what became a really straightforward question, and that is, if this passenger is unable to make this appointment due to the absence of mobility, are there patient-centered outcomes that are likely to result in an increased use of the emergency room, hospitalization, or rehospitalization? In other words, and to be blunt about it, is it cheaper to provide this trip than the likely result of not providing it? So in my 20-year career as a transit provider in a really small market, this may be the first time that I've seen the mobility argument phrased in such a stark and simple way. As it turns out, the right thing to do is also the fiscally conservative thing to do. In terms of raw volume, that is the same day and pre-scheduled trips, this program continued to grow for the next 6 months. It was originally scheduled to end on June 30th, 2015, but due to a really supportive Medicaid broker and the slow start that we got, we were significantly under budget. Eastern Oregon Coordinated Care gave us generously gave us an extension to December 2015, or whenever the money was scheduled to run out, whichever came first. In October 2015, our grant had finally been exhausted, and we were getting ready to wind down the program. And we got invited to present our project at the Oregon Transit Association annual conference when another scheduled presenter was, for whatever reason, unable to make it. And it's kind of become the running joke in our agency. We've done a couple of other conferences since, pretty much on the same basis. I'm the guy you call when the guy you really want can't show up. As it turns out, we had a benefactor in the room that day. Our regional representative from Oregon Department of Public Transit, or Oregon Department of Transportation's Public Transit Division, liked what she heard, and she was able to connect us with some bridge funding that we didn't even know was available. So that resource got our project through 2016. Since then, our coordinated care organization, again, that consortium of healthcare providers that recognizes the value in what we do, has come to the table with another $40,000. So their total investment at this point, project to date, is a little over $100,000. We were also successful in competing for a project of statewide significance from a subsequent Oregon Department of Transportation effort, and that put another $100,000 into this project for the biennium that began July 1st, 2016. So the part that you all really care about. In the spring of 2016, we brought in Ducote Consulting to perform an academic analysis on our program. Specifically, we were interested in service gaps. When you grow as fast as we did and everybody is busy telling you how great you are, and you can sit in my office and start believing your own press really easily. We made the intentional choice to stay as grounded as possible and to have somebody perform an independent gap analysis, because I don't care how good you are. If you create something from nothing as rapidly as we did, you can't do it without running the risk of leaving some very important constituents behind. In our service area, public transit is as much a conversation and a relationship as it is a service. It was important for our consultant to perform focus groups and work that measured not only what we were doing that was working right now, but also what we had left completely undone in a rush to get the project up. So we charged Nick and his team with interviewing patients and partners in healthcare, and since he'd be knee-deep in the data anyway, we also wanted to do a cost-benefit analysis. And finally, we were looking for recommendations on making the business case for local investment long-term. At this point, it may be smart to hand off to Nick Ducote real quick to describe the process, tools, and metrics he used, and some of the conclusions he reached. Thereafter, I'd really like to explore a few things that can be easily duplicated from community to community. And of course, I'll take questions at any point in the procedure. I'd much rather have you ask right away than sit in your hands and toward the end and maybe forget to ask. So, Nick, are you ready?
Yeah, absolutely. Thanks for the opportunity, everyone. Just kind of start with the methodology of the study. We started, as Frank said, he wanted kind of a bunch of different qualitative and quantitative measures that we could discuss in the study. So there was one focus group of users of the program, one focus group of healthcare providers and community health workers. There were interviews with some key informants, some people who had used the program, and some administration staff around the county. And of course, the written report that came out with the cost-benefit analysis and some summaries of all the different parts of the study. I used a lot of citations. If you see, the idea was to provide sort of information roadmap for anyone who wants to dig further into the weeds and into the analysis to try to use this information wherever you are. So feedback from the users and the clinic personnel informed the gap analysis. And that final chapter of the study is recommendations and some shortfalls and where the strengths and weaknesses of the existing program are. So a big part of the study was to try to estimate the population of transportation disadvantaged people in Union County, because that would give us an approximation of potential demand, which would then inform the cost, benefit, and effectiveness model. So in consultation with a bunch of different data sources, the American Community Survey, the local community health needs assessment, that gave us an idea of 3 probable figures that represented the transportation disadvantaged population of Union County. And that ranges from 1,100 to 5,000 people. And some explanation of that is really across the literature nationally, regionally, and locally, there is no single definition of what it is to be transportation disadvantaged. And it's very difficult to get clinic-level data from hospitals and clinics about what percentage of people are missing appointments because of transportation disadvantage. So in a way, you have to kind of work backwards from what is the total possible population to, what are some of these probable ranges. So the idea is to provide a conservative estimate towards a kind of moderate estimate and then a more liberal estimate of what that population could be. So then we took that data of what the population would be and used a lot of the peer-reviewed literature that already exists in NEMT programs and demonstrate the value on a quantitative level of providing this service. Sort of, if we could capture 100% of the market of the possible patients and users who need this program, what would the benefit be? So taking a look at different conditions like chronic kidney disease, cancer, the number of appointments that you average under the various conditions, and then a breakdown even further of what percentage of the population had these conditions, to then get an idea of how many total trips there are. And when you break it down by the different conditions, you also get an idea of the cost difference between effective managed care and unmanaged care. So then taking all those numbers into account and taking the range of 1,100 to 5,000 people, there could be a potential annual round trip number of 3,000 to 14,000 annual round trips, which breaks out to $2 to $10 million annually just in Union County in cost benefits. So that's taking, did you say something there, Frank?
Oh, I was going to just pop in for a minute for our users. We're a little slide light today, so it's just going to be 2 slides. They're not supposed to advance directly. Just to help everyone out. Please continue, Nick. I'm sorry to interrupt you.
Yeah, no problem. So kind of with those basic numbers in mind, I'll go over a little more of the details and some of the big finds that we made. First of all, the program is incredibly highly valued by patients and by the healthcare community. No one wants to see it go away. The local healthcare community and providers and nonprofit advocates all wanted to be more involved with the program once they were contacted, and we started having some conversations and discussions of how the program could better serve their patients and their clinics. Because a lot of what we found is a lot of these individuals, community health workers or clinic directors, were spending a lot of time already coordinating transportation. So they're already spending time and money and resources trying to figure out how to get patients to where they need to go. So a program like Rides to Wellness fits perfectly and can vastly expedite the process of them trying to get patients around the county, around the state, or even as far away as Boise, Idaho, Spokane, and Portland, as you see on the map there. It's quite a ways away to get to some of those larger cities. So in some of the focus groups with the patients, I think it's really important to not only look at the numbers, but to really dive into some of the stories of some of these people using the program. And one of the questions I asked was, what would they do without Rides to Wellness? And these were some of the answers that they gave. I'd be at the funeral home. I would cry a lot. My grandchildren would keep having to miss work for me. And I just wouldn't go to the doctor. So I mean, the contrast there of what happens without the program and with the program is pretty clear, and a lot of the users were very, very passionate that they were in the health that they were in a good way because of the program, especially for some dialysis patients who live outside of La Grande and Island City, which is kind of the central hub of the county and where the only dialysis clinic is in the area. If you have to travel 3 times a week into town, it's a really big burden on your family, and if you can't drive yourself, it means missing appointments, and missing appointments means a higher risk of not only mortality, but of emergency room visits or possible life flights and taking a helicopter to somewhere like Portland or Boise. So the costs are real, the costs are there. Just to dive a little bit into the estimates and what was being measured there. The conservative estimate is a very literal take on transportation disadvantaged, and it measured only those without vehicles, those with limited vehicle access, so a family of 2 or more where there were only 1 vehicle, and adults that don't have driver's licenses. And that was taken all from the American Community Survey. One of the obstacles is that there are so many different data sources, and some of them are measuring the same thing. So trying to find a single data source with unique numbers and population figures is fairly difficult. So some of it is a blending of these sources where it's appropriate. So another big help was the community health status assessment that the Grand Hospital did, and they identified 2,500 adults in the county that don't go to the doctor when they need to because they have difficulty finding transportation. So from the hospital level, that's about as detailed of a data estimate as you'll get as far as specifically who is missing appointments because they have difficulty with transportation. So then digging a little more into the numbers, I don't want to go too far into it. There are a lot of spreadsheets and charts in the study if you want to look at that. But again, a big piece of the study was calculating how many people need the service, how many round trips would occur each year, and then factoring in, we were able to take cost estimates from Frank or not estimates, but real actual costs of how much an ambulatory costs or how much it costs to transport someone in a stretcher, or and all those admins and infrastructure costs that go along with that. And then the model also took into effect the cost of the health care provided. So it's a direct value to the hospitals and the clinics that you're obviously bringing patients right to their doors. So that's where you get the total benefits and then the total net cost effectiveness figures of $2.2 to $9.8 million annually. And I think just one thing that I'd like to end with are some of the big big recommendations that I came out with and some ideas of how to make some of this data more robust. As Frank said, HIPAA restrictions are a big obstacle to getting better data on a transportation level to try to figure out who is out there to be served. So one idea I had was to take, kind of like Frank said, where if he knew who the 15 highest users of the emergency room were, it would be really easy to move the needle, at that specific hospital. So I envisioned something like a trial program at a hospital and a study conducted by the hospital where patients sign on to essentially a high level of service rights to wellness program. And you could directly measure some cost and some not only cost but cause and effect of how this is affecting their health and emergency room utilization, even on a small level. So I think that would be a step towards not only integrating transportation and clinic level service, but trying to get some more robust data on what happens when this service is provided on an individual health level, because that's definitely something that's missing. Another issue that came up, a big help and a big stakeholder in the process was the Women, Infant, and Children's Clinic. Providing rides to some of those populations can be really effective because you can get potentially 4 to 5 visits in a family all go to the doctor in one trip. So you have one trip, multiple visits. Your average newborn and child is going to go to the doctor a lot. There are a lot of obstacles in providing that transportation because of liability issues on a transportation level with federal transit funding. It's limited how you can respond and accommodate young children in your vehicle, whether you have your own stock of car seats, whether drivers are trained to use them, and the different liability insurance issues. So this is kind of an issue where we ran into some limitations just based on the way the laws are set up now and the way the funding structures are set up, but it's a big need for these young families. The Women, Infant, and Children's Clinic estimated that 10% of all of their appointments are missed because of transportation-related issues. So they deal with a lot of phone calls from people trying to figure out how to just get to the clinic to take care of their young children. So that's one issue where there might just need to be some creative problem solving.
Absolutely. We do have one question right now, I think probably for Frank. For transporting both Medicaid and non-medical patients, who's paying that cost when it's not covered?
Okay, so this will be one of the things I talk about when we talk about things that can be easily replicated. We realized early on that we needed to act almost as a one-stop call center. So if you're one of those folks that Nick discussed who is working at a hospital or a clinic and you're spending a lot of time on the phone trying to arrange transportation for your patient, you don't know anything necessarily about straightforward programs like eligibility for ADA paratransit, and therefore how much less do you know about complex programs like Medicaid. So we said, look, you call us, we'll figure out what the passenger is eligible for, we'll contact the brokerage because we are the low-cost provider anyway, and they've been really receptive to working with us. You know, they'll approve a same-day trip as long as I've got capacity to provide it. So for passengers who aren't, I mean, if the passenger is Medicaid eligible, that's where we're going to send them. If they are paratransit eligible, we're just going to serve them in that way. If it's a paratransit eligible trip within our area of service, if they're not, that's where the Rides to Wellness program comes in and pays for the fully allocated cost of the trip. I can't charge 1 penny less because I'm a Section 5311 provider and I can't use federal funds to give me a competitive advantage over somebody else who might want to provide the same service. But I don't have to charge 1 penny more. Usually that makes me the low price provider in any market, and I'm able to produce a lot of those trips for a private nonprofit cost profile. So it's worked out really well with, I mean, the only thing we really had to do was adjust our thinking. So, and I'll talk about that too under things that can be replicated. We had to adjust our thinking about how we account for those trips in our software. So if I have a paratransit vehicle that is going with a paratransit passenger to deliver to Grand Ronde Hospital, the person they pick up from Grand Ronde Hospital and take home may not be paratransit eligible. Therefore, we have to adjust a code in our systems so that we can show them as a demand response dial-a-ride, because the vehicle doesn't care who it's serving. You know, and in getting that mindset through to our staff and our passengers, we've actually ended up with a lot more efficiency from our public resource. So it's been a win-win for everyone. Did I answer that question?
You know, I think so, but I'm actually going to unmute both of the folks who've asked questions right now. And if they want to ask questions directly, they're more than welcome to. And if it's loud, I'll just remute them.
Okay, cool.
And as a reminder for our speakers, if you guys would just say who you are. I know I didn't introduce myself.
Sure.
I'm Jerry Emanuel. I'm the Resource Center Manager with National RTAP. David or Vanessa, are you guys on the line? Would you like to ask a question?
Can you hear me?
I can.
Yeah.
Oh, yeah. So you are a service provider, correct?
Yes, ma'am, I am.
And so in terms of credentialing, what type and what level of credentialing or background checks do your drivers undergo?
Oh, yeah. Our blanket purchase agreement with our Medicaid provider requires us to do criminal background checks. We're looking for, you know, pretty much anything that's a felony in the last 15 years is an instant disqualifier. If there are misdemeanor charges, and depending on the severity and how long ago they were, they're pretty much instant disqualifiers. Our guys all take defensive driving courses annually. They take CPR, first aid, first responder, the passenger assistance, securement and sensitivity, and there's something else. The bottom line is they're extensively trained and retrained every other year, and of course they're all in our Section 5311 drug and alcohol random screen pool. So we don't require commercial licenses for all of our guys because most of the folks driving vehicles for this particular program are in either minivans or cutaway buses of 14 passengers or less. But of course, if we have vehicles of, sometimes we have 20 passenger vehicles that would be in this mix. And if that's the case, then we'll have commercially licensed guys who are also subject to annual physicals. Did that answer your question?
It did. Thank you.
Yeah, and we're also, just tangentially, we're insured to the ITEEF. I think our policy with the brokerage requires like it's $3 million per person, per incident, per accident. So it's a lot higher than what our standard would be under FTA's grant agreements.
Mm-hmm.
Great. So I encourage people to keep raising hands and asking questions. I'm happy to unmute you. Frank, do you want to talk a little bit about the 2 slides we have today? I think we've just sort of left them.
So it actually kind of feeds right into the things that I wanted to talk about that I thought would be pretty easily replicatable in every community. The one that you see in front of you, at least it's on my screen, is got Union County, and it's showing you how far I am from the nearest metropolitan areas where a lot of medical services are available. We also pulled from, I think this was the American Community Survey, the populations of our incorporated communities, and then tried to figure out how far they actually were from a hospital. You'll notice that most of them don't have pharmacies or clinics in any of them, and it seems like the further you are from a hospital. Yeah, can we pull up the other slide? Okay. So we also pulled from the American Community Survey the number of households in the communities, the number of households who had no vehicle whatsoever, and then we looked at the number of households where there were more than one person residing but less than 2 vehicles. Our rationale there was these are very small communities, and job opportunities, especially family wage jobs, are probably pretty rare. So when the primary breadwinner takes that vehicle and goes out of the community in order to secure a livelihood, whoever remains in that household is effectively stranded as if the community or as if the household had no vehicle for the purposes of medical access or anything else for that matter. So even after 20 years in this gig, I was really surprised in my own community about the prevalence of transit disadvantaged people in our bedroom communities. I mean, I'm looking at places like Cove, Oregon, 250 households, and upwards of more than 10% of these households, if the primary breadwinner is gone with that vehicle, are stranded. If you roll an ankle or blow out a knee or have a high fever, you're in for a really bad day. And the chances are by the time you actually get treated, you're going to need a lot more treatment or a lot more costly or invasive treatment than you would have if we could have just got you treated right away. And there's some things on our community, on the models that Nick used to show our cost effectiveness that frankly aren't even measured. I mean, if you look at our little community of Cove, they have one, I guess you could call it a grocery store. It's one of those places where they sell gasoline and pretty much everything you need to live in a small town. And you could probably measure their produce section with the ruler that's in your desk. So even if we can get folks access to medicine long term, it seems like we're fighting an uphill battle if we can't get them access to the basic things that people need to have a healthy lifestyle. There's a whole lot of things in the model that, I mean, bottom line is we've done a lot of good work and the model reflects that, but there's a lot more work to do and we don't have models that reflect that yet. So does that give you kind of what you're looking for there, Jerry? Did I leave anything out?
Yeah, I think so. Absolutely.
So the things I think that can be easily replicated from community to community. I mean, we've had a lot. The more I travel around and find out how everyone else is struggling with these issues, the more I realize how lucky I am to live in Oregon in general and in the district where this coordinated care organization resides specifically.
Absolutely.
But, community health needs assessments are required. Do we have another question?
We do.
Okay, I'll wait.
So we have two questions. Kelly, are you on the line? All right. We'll wait a second there while we figure out that audio, and I'll ask a different question. Taking the highest estimate of transportation disadvantaged in Union County, is there the capacity to currently meet their transit, like within the transportation systems available?
I can answer that definitively. There is not. It will require much more investment. In fact, our program isn't done growing yet, so I can't even tell you at the moment how much per month is enough to get us just to cover the need that's presented to us. My guess is if you ask me again in another year, I'm going to have a lot better answer for that question.
Okay, so is that like a follow-up to the current study, or
yeah,
how are you?
The grant that I talked about toward the end, where we've been given a little over $100,000 over the next 2 years, one of the end results of that project is going to be a complete white paper on how this type of thing can be done in other communities around our state and probably around the nation. So we'll be bringing Nick back in for, or whoever our successful consultant is, for some of that follow-up stuff. Nick, do you have a better answer for that? Do you think I'm going the right direction?
No, I think you are. It's so hard right now. I mean, there could be a lot of things done to make it more efficient, as it grows or takes on certain patterns. So it's a flexible program.
Yeah, I'll give you a key example. This would be like the Holy Grail. We, as a community of transit providers, do a really good job of coordinating with the medical community, but I'm not convinced that the medical community is coordinating very well with us, at least not yet. If we could figure out a way to get our providers who do, say, oncology in Walla Walla, Oregon, or neurology in Boise, to say, look, we're going to book oncology appointments from Union County on Tuesdays so that we can actually load up a bus and use the capacity of a vehicle rather than sending 3 drivers down the road that week, we could serve a lot more people a lot more cost effectively. And as Nick pointed out, there's an economy of scale, or there's an efficiency of, there's an economy there for the provider themselves, because you're going to get a load of passengers all at the same time that we can work in over the course of a day rather than hit and miss. You can actually schedule a day around it. That's a goal that's a long ways out. I mean, those are conversations that we're just now beginning to have. And since our primary providers of that kind of care are both out of state, our coordinated care organization is a great place to have it's a great jumping off point, but it's not the be all and end all because the other states haven't caught up with us yet. So I think that, stay tuned. That's probably going to be the next big thing we need to work on to get a breakthrough that's going to move this project to the next level. Was
Great.
there another question?
Yeah, can we try the line one more time, like a call-in show here?
Okay, this is Kelly from South Carolina. How you doing, Frank?
Hi.
Got a question about, sounds like y'all are doing a great thing. I'm curious, though, as to how y'all do your program cost allocation when you have rides that are shared between non-emergency transportation and 5311. Do y'all have a methodology for doing that?
I do, but I don't know that it's the best one. So if you've got a better answer for me, I'm going to be really receptive. Essentially, when I'm putting these things together on a single bus, my assumption is, especially, okay, let's say I'm going to the hospital and I'm picking up 3 people, and the one who lives the furthest away is my Rides to Wellness passenger. Rides to Wellness is going to pick up that entire trip, and we're going to drop them in sequence. And the reason I'm doing that is I don't want to mischarge a program for something that someone else could be paying for. I have to be very careful with how I mean, I can use that money as match maybe, but I can't really bill it to a general public ride if I've got something that a private third party is paying for. Does that make sense?
It does.
So it's not the best model, and I'm certain that we could come up with some sort of estimate, but especially when I'm not in control, because the demand for especially medicine is so asymmetric. I mean, some days I'll have a lot of people in a bus, some days I've got one guy in a bus. So how do I allocate those out? And in the interest of holding my primary partners harmless and not doing anything I can get in trouble with an auditor for, I'm just better off billing it to the Rides to Wellness program. Does that answer the question?
Yes, it does. I appreciate it.
Do you have a better idea?
Nope, I'm struggling with that myself.
Okay.
So one of the things that had been proposed, and our current system just doesn't track things that way, is looking at the percentage of passenger miles and doing the allocation that way.
Which should probably, I mean, I'm not opposed to it. I just feel like I want to be very careful with my federal funding sources, and I'd rather build this private model that we've put together and end up paying a few extra bucks a trip than I would do anything that is going to get me in trouble with an auditor down the road.
Sure.
I mean,
sure, and I agree with that wholeheartedly. And we're trying to develop business cases. This has come at a really good time. We're trying to develop a business case in support of public transportation overall in our region. And so this will be very beneficial for us to use as a jumping off point. I really appreciate it. Very timely.
Well, one of the really cool things that we learned in this project is, especially with the one-stop call center, is that it was so prevalent for, I'm just going to pick on oncology. The oncology department in my hospital probably doesn't know off the top of their head how many rides I'm making possible for them. But I promise you the director of that department knows that his staff and his clinicians are not wasting a lot of time on the phone making those trips happen anymore. So having a guy like Nick come in and give us really good data that we can present, it's going to take them a while to wrap their head around that. It's highly visible and immediate that they can see the cost savings of returning their clinician to actually working with patients rather than being a trip broker. I say this in my presentations, it's probably getting old, but we don't cure cancer. Maybe they shouldn't spend a lot of time brokering rides, right? I mean, if you do what you do best in your community, it tends to work out really well, and I think the economy of what we're doing becomes self-evident. It just takes a little time for them to get their heads wrapped around a new model because, you know, we as a society, we don't get to keep the money. We can keep wasting it in an inefficient healthcare system, or we can invest in programs like ours where we can clearly show that there's a huge return on investment. You know, public transit just doesn't, we don't assert ourselves enough. if you folks are not participating, I mean, a community health needs assessment is a requirement under the Affordable Care Act for all nonprofit hospitals. I did some research prior to this presentation. There are 5,627 registered hospitals in the U.S., and about half of those are not-for-profit. So the odds are just better than 50-50 that a hospital serving all or part of your service area is a nonprofit. If they're not asking about transportation as a physical barrier to care, we really need to get in and start educating them. If you're not in the meetings if you haven't been invited to previous meetings when the community health needs assessment process is being discussed and is open for public input, invite yourself. They need to hear from you.
Sounds great. Thanks.
Yeah, Nick, are you still on the phone? If you wanted to talk a little bit about how you, the 2005 study and the spreadsheet that are at the back of that.
Yeah, absolutely. So I used the 2005 Hughes-Cromwick study. That was the basis of it was to try to create a tool that could be used in places like Union County to estimate the cost-benefit effectiveness of these non-emergency medical transportation rides. So the first thing I wanted to do is try to find out the best local data that we could use, because the spreadsheet's really flexible in that they have national averages for all the fields, but they make it really simple. I'm pretty sure they're highlighted fields where you can come in and input whatever local data you have that's better. So we were able to take Frank's cost information. You know, how much per hour, per mile, per ride does it cost? What is the distribution of ambulatory rides, wheelchair, scooter rides, and stretcher rides? How much do those cost? And then the information that we didn't really update, because it's really so sound, and to make a better model than that would take a lot more resources and time than we have available here. But you know, the distribution of chronic conditions, and then the cost of poorly managed care versus well-managed care. And one sort of, not a bad thing, but a limitation of using this information is I didn't even adjust the figures for inflation. So these are technically in 2005 dollars that a lot of this is based on. And there are a lot of updates that I could kind of do to this model, but I wanted to keep it as pure as possible, because I'm not going to be going in behind it, updating all the methodology and making sure that everything lines up, you know, on the outside. I just wanted to take the best data I could, you know, from the American Community Survey, from the Community Health Needs Assessment, and program data from Rides to Wellness, plug that into the fields where it fits, and I did 3 different models with each of the, you know, the conservative model of 1,100 people needing the service, 2,500 people, and then 5,000 people, and then that informed the total net cost effectiveness figures that you see there. Does that answer the question there?
Yeah, I think that's great, because the thing is that we are, as transportation providers, and someone earlier said, we're just trying to figure out how that we can monetize the benefits in ways so that someone besides us and our customers can see the benefits or understand them a little better.
Absolutely. And Nick, the 2005 study you were just referencing, is that something that our viewers could get a hold of as well?
Yeah, I have the full citations on page 6 here. The name of it's the cost-benefit analysis of providing non-emergency medical transportation, and it was a TCRP project.
Okay, excellent. So we can dig that out, and we'll be sure to include it in the follow-up email that all of our attendees will get after the call.
If it would help, I can type the citation here in the chat window.
Yeah, absolutely.
Sure.
And then I have my own question while people are working on this and thinking up any additional questions they'd like to ask. When you were going about getting started with the study, did you do outreach to the healthcare providers in the area to see which metrics they would use or if they were different from kind of what you expected to be needed?
I did. I went to the hospital and tried to dig into some of their econometric data, some of this, but they really don't have robust modeling. They really don't have even staff that is dedicated to this kind of thing. I was able to get a little bit of data as far as some of the clinics and how many people were missing appointments, but I mean, some of the information I really wanted was, what does it cost the hospital when somebody misses an appointment? And that just wasn't something that either they had or that they were comfortable sharing with me. So as far as the interactions go with this study in the hospital so far, they seem pretty receptive. I think it is a little hard to imagine that the benefits can be that large. But I think when you really start digging into the details of how many people can be served and what's missing in a community like Union County with such a rural area, I think it's becoming a lot more clear to the hospital, and I think they've even got some ideas now of some ways they can study this information and use those figures to try to figure out some of their own cost information. But they're really, so many hospitals are so overwhelmed, it seems, by just keeping up with changing regulations every year that it's really hard for them to get ahead and kind of make a jump on data and analysis, at least at a fairly small rural hospital like we have here in Union County.
Absolutely. Kelly?
Okay, thanks once again. I have one more question. One of the things that we do provide with the non-emergency transportation is people can go to the doctor, they can go to the pharmacy and pick up their medicine, but if they need a roll of toilet paper, they're not allowed to buy anything other than their medicine at the pharmacy, and it makes no sense to restrict a transportation disadvantaged person from meeting some of their basic needs. How do y'all get around that?
Well, we try not to ask any questions. If you need to go to the pharmacy and you want to pick up a dozen things while you're there, I put on my transit provider hat, especially for the Rides to Wellness program. This is a demand response public transit system. I'm not in the business of limiting what you as a consumer can purchase while you're making a legitimate medical transaction. I mean,
yeah, I wish our medical broker would agree with that.
You know, there's an advantage to having my broker several counties away. They trust me to do the work. I don't generate complaints. My guys take really good care of the passengers. We follow the rules. I'm not going to beat anybody up if they want to pick up a couple of bags of groceries while they're getting their prescription for metformin filled. They're going to be there for 30 minutes anyway. They got to be doing something. It's not like it hurts my time. My guy's going to go take care of three or four more deliveries while I'm waiting for this passenger to be ready to go home anyway. You know, I don't feel like I have a dog in that fight. You know, and if I do, then I should always err on the side of the passenger. So, and so far I haven't been called on it. So, thanks for the heads up. That might not always be the case, right?
Hopefully not the case. Thanks.
Hopefully not. Frank, could you talk a little bit about your relationship with the leadership of the community care organizations?
Yeah, our agency, okay, so public transit is a very small part of our agency. Our agency is huge. We have an area agency on aging, a community action agency, you know, everything from food bank through Department of Energy is us, and it's just one of those conditions of living in a very small town. So I attend the coordinated care organizations every month, or their meetings every month, but I'm not actually a voting member. Another member of our organization that has a lot more broad community focus other than just transit is our voting person. They track my reports every month. They have formed a small subcommittee to help me deal with some of the budget issues that were resulting from, you know, a lot of trips leaving our market that we never anticipated. They've done an excellent job in helping me raise additional resources. Like I said, they're into this project for $100,000 already. I expect them to come to the table for another $40,000 in January. There will be a point where I need to start weaning myself away from that and toward a more stable source of funding. There's nothing worse in the world than having to tell a passenger, yeah, sorry, I used to have a grant that took care of that trip, right? But I feel like they've created a really good foundation for us to work with and to meet a need that they themselves helped identify. It's been a privilege to be sort of just in the right place at the right time with the right forward-thinking organization to work with these folks who are going a brand new direction in healthcare.
Absolutely, and it sounds like they really appreciate the return on investment that you're generating with these NEMT trips.
Yeah, the Coordinated Care Organization is a big fan. And moreover, what they're finding is that some of the indicators of health that they're trying to affect are being now, I can't make the causal case that because I'm delivering people to a walk-in clinic rather than the emergency room, that's why the emergency room utilization rate is dropping. I'm correlated, but it's not, I don't get to claim responsibility for that. However, the fact that these rates and they're also dealing with smoking cessation and diabetes management and fetal birth weight and postnatal birth weight, things that other indicators of health that they're trying to affect. As a result of their progress, they've been given additional resources to work with, and more often than not, those resources are presently coming to me to continue the work that we've started.
Okay, I mean, that makes a lot of sense. And Nick, maybe you can talk about challenges kind of quantifying the correlation and really showing that as solidly as possible. Does that make sense? I know that obviously you can't prove causation necessarily.
Still there, Nick?
Sorry, I was on mute.
Oh, you're good.
Happens to the best of us.
Yeah, just trying to find the correlation there was really just, if I had a lot more time and a lot more resources and some more flexible time to really dig through some different data sources and work with the hospital and have access to data that they just don't want to give, people outside the hospital access to, or really even other people inside the hospital can't access some of this data. I think the best way to try to move towards some more robust data would be to do something like a pilot study where you really integrate the transportation and the hospital service and you get some, even on a very micro level, you would get some excellent data on patients and what happens to their health, how much it costs, what it looks like in time spent for hospital administration, what it looks like in time spent for transportation level administration, and really get some quantifiable cause and effect and correlation and look at how a program like that can impact people on an individual level and the system on a greater level. But I think right now it's, you can make some basic arguments, based on where people are going and some assumptions you can make, but the more assumptions you make, the less robust and predictable that data and those conclusions are going to be. So
I would sort of, if you don't take anything away, and this is Frank Thomas again, if you don't take anything else away from our presentation, I'd encourage you to take Nick's contact information off the slide. Shameless pitch for my guy. He delivered this project in a really tight deadline, like 12 weeks. Came in 12% under budget. You get your money's worth here.
Appreciate it.
Excellent. Well, guys, we're at about an hour, and I see that people are starting to drop off. I know that there are more questions to be asked, and this is a big topic, so I encourage people to take the slide, take down your information. You can also reach out to National RTAP directly at the info@nationalrtap.org email. Unfortunately, I neglected to put all of our contact information in one slide, so I'm going to leave up our presenters, as I think it's a little bit more valuable and harder to find. And just have a last call for questions now, and if not, I'll thank you guys and send you onwards. Robin, do you want to add anything to that?
Jerry,
Sorry,
this is Dave Raphael. Can you hear me?
Yep.
Yeah.
I just wanted to say this was a great presentation, and to Frank and the folks there in Union County, that I think you're really on the cutting edge of where NEMT is and should be going. I found your presentation really exciting. I want to look at the study that you did, and I may have a few questions I'd like to email to you afterward, if that's okay.
Absolutely.
Wow, thank you.
Oh, this is great. I think this is the beginning of the conversation. This isn't the end of the conversation. And you know, what we're happy to do is take the questions from here and look at whether there's other webinars or discussions that we could have. I know David Raphael, who was just on the phone, they're working at publishing a TCRP report on the relationships between transit and the brokerages around the country. So I think that for us going forward, we can look at what are the opportunities to look at these different pieces and have another webinar or maybe more information if people have other questions about non-emergency medical transportation and what you can do in your community. Send them on to us, and we'll look at getting experts or your peers who have tried different strategies in to talk about it. So thank you, everyone, and thanks, Jerry, for making this happen, and we'll be in touch with everyone.
Great. Thank you so much again.
Thank you.
And everybody,
Thank you.
have a great week. All right.
Bye-bye.
Again.
Bye-bye.